All right, thank you. I'm going to start the presentation again now that we are sharing. Sorry about that. All right, thank you everyone for coming. We are presenting today our panel session or workshop on how we have been developing living guidelines in the midst of a pandemic and our experience in the task force, in the National COVID-19 Clinical Evidence Taskforce. So first of all, where we are, where the guideline stands now. We are currently published version 45.1. So this has been the last update. We have over 118 clinical questions and a few more recommendations. The guideline is freely available on our website and also through Magic App, which is the guideline portal. And this is just a brief outline of the sections and the different areas of COVID-19 treatment that we are currently developing and giving answers. So this, as I was explaining before, this panel session is going to have different sections. First, I will introduce the panel speakers. Second, I will give an overall presentation on what is the task force and how we have been developing the guideline. And this just will be a starter, and we will then move into the question time, which is the main part of this workshop. And I want to encourage every one of the attendees to send us your questions, to write them through the chat, start thinking on them, and we will come back to these questions after we finish the presentation. As I was saying, this panel session is going to be structured as a conversation between us and your speakers. We don't want to just give a talk and close everything. So we really encourage your participation. And it will then conclude with a closing remark for each one of our speakers. So who we are, this is the panel speakers, sorry, that we have for today. And this is just a small part of the whole evidence task force of the methods team. And thanks all of you again for joining and speaking today. The first speaker is Heath White. He's the Deputy Director of Evidence and Methods at the Australian National COVID-19 Clinical Evidence Taskforce. And he's also the evidence lead for the Living Evidence for Diabetes program based at Cochrane, Australia, Monash University. Prior to this, he has worked in the NHMRC, contributing to development of Guidelines for Guidelines program. He has also worked in systematic reviews and clinical guidelines at the Joanna Briggs Institute and also with the Royal Australasian College of Surgeons. And he's also a member of GENE Network and part of the GENE AMS Steering Committee. Next is Saskia Chain. She's a research fellow in Living Evidence Methods at Cochrane, Australia. And she's currently working on developing methods guidance on how to conduct living guidelines. Saskia has been working as also part of the task force. She has been the methods lead for 3 of the clinical panels, the panel of care of older people and palliative care, critical care panel, and the hospital and acute care panel. And prior to this, Saskia has also worked on the University of Sydney, developing public health guidelines and conducting health technology assessments. Saskia has also worked previously at NICE in the UK as a research fellow and also developing and conducting evidence reviews and guidelines. Next is Samantha Zacaborti. Samantha is an implementation scientist and she works as a primary care researcher. She has extensive experience in clinical guideline development and implementation, and she's the methods chair of the primary and chronic care panel in the task force. And she is also a senior research fellow at the Department of General Practice at Monash University. Samantha's work is focused on improving clinical care through the practical and effective use of research, especially in primary care. Tari Turner is Associate Professor and is the Director of Evidence and Methods at the National COVID-19 Clinical Evidence Taskforce, where she has been leading the development of the living guidance for COVID-19. She is Associate Professor at Cochrane, Australia, and she also leads the research on developing and evaluating methods for living evidence synthesis, including living systematic reviews and living guidelines, and translating this into improved healthcare practice and policy. Next is Joshua Vogel. He's Associate Professor at the Australian, and he's also an Australian medical doctor with a PhD in maternal and perinatal epidemiology. He's Principal Research Fellow and co-head of the Global Women's and Networks Health Group at the Burnett Institute. And his research work focuses on maternal and perinatal health and issues affecting women and families living in resource-constrained settings. His areas of interest are clinical trials, epidemiology, and guideline development. He helped co-establishing in WHO living guidelines for the program in maternal and perinatal health, and he has been also collaborating in the COVID task force as the methods lead for the pregnancy and perinatal care panel. So, sorry, and the last one is me, sorry. I'm David Fraile Navarro. I'm a research fellow in living evidence methods at Cochrane, Australia, in Monash University. And in the task force, I've been leading the pediatric and adolescent care panel. I'm also doing a PhD at Macquarie Uni in the Australian Institute of Health Innovation. And my background is in general practice. I'm a trained GP from Spain. Prior to coming to Australia, I was working as an academic clinical GP in the UK. And I also been collaborating with the Ibero-American Cochrane Center in Barcelona in the projects of guideline evaluation and evidence application. So this is us. And as I was saying, I encourage all of our attendees to start thinking their questions. This is our website. The guideline is available at Magic App. You can have a look. And we also publish a number of papers on our methods and specific sections of the guidelines that are available. And please reach out to us if you have any queries, any questions. And yeah, we are getting this started now. Thanks again. So before we get into the questions, what I would like to give you an idea is who we are in the task force and what we do. The task force brings together 32 professional bodies across Australia, and our aim is to provide a national evidence-based voice and guidance for the clinical care of people with COVID-19. And to do so, we are undertaking continuous evidence surveillance, identifying and synthesizing rapidly the upcoming research on the COVID-19 space every week. And the idea with this is we wanted to offer a trust and unified national voice for Australian clinicians and how they can provide clinical care for COVID-19 patients. These are our member organizations. As I was saying, 32 organizations across Australia. We have been working and collaborating with over 230 panel members, clinicians, nurses, consumers. This is just a small sample of all the people that we have been involving, and without them, this guideline won't be possible. So this is the real doers of this guideline and the real people that is behind us. Our partners and our funders. And also I have to highlight that the COVID-19 guideline is part of the Australian Living Evidence Consortium. We also have and are developing living guidelines for diabetes, for stroke, for kidney disease, and a number of other diseases. And we are also collaborating with digital platforms such as Covidence and Magic App, and we are also in the process of incorporating new ways of doing things and developing the evidence for our living guidelines. So how do we work? So with our living guideline, each week we identify, evaluate, and synthesize the upcoming evidence, and this becomes the working piece of the new recommendations. We identified, and this is done with a daily search, with daily searches, the new evidence that becomes available. And then once we review, synthesize this evidence, we present it to a panel of clinical experts that they review the evidence and make new and updated recommendations. That then, if they follow in the approval process, is published online every Thursday. As I was saying, the guideline development process, it starts as with other guidelines. We start with a clinical question, with a number of clinical questions, and we develop a specific pick of questions for each one of these clinical questions. Then we do the literature search for any treatment of COVID-19, and this is conducted daily. We search for randomized clinical trials. Sorry. Then we also, sorry, my presentation is doing something strange. We also screen weekly for studies in diseases such as FIMS-TS, for respiratory support, for number of conditions that are related to COVID. And then the guideline panels are meeting, and we are in the process of updating our processes for the sustained mode and for the long maintenance of the guideline. Currently, they are meeting fortnightly for developing guidance and recommendations and flowcharts. And then once these recommendations are created, they are reviewed by the guideline leadership group, which has members from all the panels. And then this is submitted to the steering committee, who gives their sign off and has the final word before the guideline is published. We have been our expert panels, and we have been incorporating and adding different panels of experts since the guideline inception. And currently we have a primary and chronic care panel. We have a hospital and acute critical care panel, a panel specifically for disease-modifying treatments and chemoprophylaxis, a panel on pregnancy and perinatal care, pediatric and adolescent care, care of older people and palliative care, and we also have an infection prevention and control panel. On top of that, we have an expert advisory group. We have a pool of experts that when we have specific questions that require additional expertise, we convey and ask for their advice. We also have a cardiac arrest working group, the evidence team, an observational data working group, and also an independent conflicts of interest committee. This is our overall structure, and looking at this picture might sound complicated, but as I was saying, it starts with a PICO question, with the literature review. Then we present this to the different panels who draft the recommendations. We also incorporate the views from the consumer panel that I haven't mentioned. And with this, it all goes to the guideline leadership group. Which also is reviewed by the Conflicts of Interest Committee. And this creates the final set of proposed living recommendation that goes to the steering committee, and then this is approved and published. So before we move into the questions, just a general reminder for everyone on what are living guidelines, how they are different from our traditional guideline development processes. So a conventional guideline, usually it took between 3 to 5 years to update, and generally it follows this sort of structure or hills that we have to climb. We start with defining the scope, developing the systematic review, developing the guideline, publishing, approving it and publishing, and then the guideline becomes outdated as the time passes, and then we need to climb this hill again, and review the whole process. Instead of that, with the living guideline, where we climb this hill once, and then we keep updating, and we keep surveilling the evidence continuously. And this is very important, especially when addressing a topic such as COVID, with everything was new, everything was changing every week. The traditional guideline development model was not really possible to produce a meaningful guidelines, especially also with the time frames and the urgent need that we have for COVID guidelines. So just to resume that, our overall approach for guideline development, we are conducting multiple de novo systematic reviews or living systematic reviews. We use grade methods. This guideline model doesn't preclude cutting corners on rigorous evidence-based approach and review. With this, we came with evidence-based recommendations, and we use the Magic App platform to publish and create the guideline. Sometimes, when there is no evidence available, or when we are producing flowchart, which is one of the accompanying products to our guideline, we also adapt other guidelines from other organizations. We produce evidence-informed practice statements, and this is also incorporated into the clinical flowcharts, which accompany our recommendations. So where we are in terms of numbers, these are data from the last month, from October, but we had over 200,000 users, more than 300,000 sessions, and over 38,000 flowchart views. We have 32 member organizations, over 150 recommendations, more than 200 volunteer time hours per week, and more than 215 people contributing to the guideline. And this has come to the screening of over 19,000 citations across our living systematic reviews. And just to have in mind how big the numbers and how impressive has been the research and the outputs in the COVID-19 space. This time there are over 19,000 COVID-19 studies and over 5,000 systematic reviews only in COVID-19 registered in Prospero. Magic App, this is our platform for guideline development. We have been using it extensively. This is where we create our recommendations, where we display our evidence profile. It also have all the additional accompanying pieces, such as the evidence to decision framework, rationale, and practical info. And this has been one of the key elements of the whole guideline development process. Great methods, as I was saying, doing living guidelines doesn't preclude cutting corners on using grade and using a proper appraisal of the evidence and the certainty of the evidence behind our recommendations. So this has been a key element, and this is something we have been doing for all our recommendations. Clinical flowcharts. We have a number of flowcharts that are accompanying these recommendations, and I invite you to access them. They are available on our website. And just to conclude this, we have been producing living guidelines for chemoprophylaxis, disease-modifying treatments, respiratory support, pregnancy and perinatal care, child and adolescent care, palliative and aged care, and a number of conditions related to all of this. We have a platform for submitting questions from frontline clinicians. We have different ways that people can access and contact us. We have through our website, through our emails, through professional bodies and organizations, we have been receiving clinical questions and receiving feedback and incorporating them into the guideline. And the last part is the dissemination and communication. We have a website, we have a communique that everybody can subscribe, and we send every week with the news from our development team. Twitter, internal communications between the members, and also we have been engaging in recent media with interviews, press releases, and this has been also a very good way to disseminate our work and to provide clarity and a source on these agitated times, especially for media and in relation to some of the most controversial treatments. And just to keep in mind, this is possible with the collaboration of our evidence team, and also because we have a lot of fun developing this guideline. We like to dress, we like to meet, and this is what has made possible developing the guideline. Thanks again, and I will stop here and I will start with the question time. So please, if you have any questions, this is the time to start sending them. You can raise your hand, you can raise the question through the chat, and we are very happy to take them. Thanks. All right. So until some questions come, I'm going to start asking questions to our speakers. So in that way, we can also make the people think on what kind of questions they can ask and what are the challenges that we face. So my first. I see that there is a question. Paul?
Hi, good morning, and thank you very much for the presentation. I actually worked with Saskia back at NICE about 5 years ago when we first started getting into updating discrete parts of guidelines, and MAGICAP had only just come out, I believe, at that stage. So since then, I've been out of the guidelines development kind of world. So it's fascinating to see the evolution of into living guidelines, and a bit of a coming of age with and very good timing to be able to use these kind of methods when the pandemic started up. My question is, as a health economist, I'm wondering the degree to which economic evidence has been incorporated into this process. And I guess there's two components to that question. First is the degree to which economic evidence has been considered in the COVID-19 living guidelines specifically. And then the second component is how well MagiCap as a tool for guideline evidence development can handle economic evidence.
Thank you, Paul. Tari, do you want to answer this question?
Sure, thanks, David. And thanks, Paul, great question. So the very short answer is that we made an explicit decision at the beginning of this process, which now seems like a very long time ago, not to include detailed assessment of cost effectiveness data. Essentially, that's for two reasons. Firstly, there wasn't any. And secondly, we were working at such speed that we didn't have the time to do full, what might be an HTA or similar kind of cost-effective analysis. Your question comes at a really good time now, because we're starting to see more economic analyses and cost-effectiveness evidence emerging. I think it's early days, and we've started to talk a bit more about how we might at least enrich the parts of our guideline evidence decision summaries that are about costs, feasibility, resourcing, those kinds of things. But currently, no, within the COVID guidelines, we haven't taken a cost effectiveness approach. I think that's also reflective of a bit of the principles that have been applied more broadly within the pandemic. We haven't been putting a ceiling on interventions based on costs. We've just been looking for what works. Josh, I can see you might want to pitch in too.
Yeah, no, Paul, it's a great point. And I think, obviously the whole kind of living concept space is really active and exciting. And a whole set of work has been done about, what does living effectiveness evidence look like? And I think it seems to me like we're at a point now where that's kind of clear how to operationalize it for systematic reviews and for guidelines. But then how do we extend those concepts to other types of syntheses? That might be economic analysis evidence. It might be qualitative evidence. But my impression is that that's throwing up all kinds of new challenges, and the degree to which the tools and sort of methods that we have now can be adapted versus we need kind of de novo thinking, that might be ways of presenting evidence, or it might be ways of summarizing and communicating it to panels. I think that's still kind of very much an open question, but it would make sense that tools like MagiCap or any digital authoring platform still provide some centralized resource where any evidence considered for a guideline recommendation is available there in some sort of digestible form.
Thank you. We have two questions from the chat. I will go through the first one from Priya. So Priya's asking, good morning, thanks for the insight. Would you please comment on reviewer fatigue in the process, especially since the review cycle never really stops? Anybody wants to address this question? Heath, Saskia, Sam?
Yeah, sure. I suppose that's a very good question. I suppose we've been going for over 18 months now, just constantly reviewing the new evidence as it comes through. And yeah, as you're saying, reviewer fatigue can obviously be a thing. I think it's helped by the fact that it's so diverse. We're never sure exactly what's going to come out at us. So we might wake up one morning and there's a brand new asset in a therapeutic we've never even considered before. And so it's almost like a brand new topic we're looking at. So although, we do have to kind of go through the cycles over and over to kind of maintain the recommendations and update the evidence profiles as the new evidence comes through. It's just, I suppose, having a fantastic team to work with. We meet every morning, slightly less frequently nowadays, but at the start we met every morning, every afternoon to go through the evidence, discuss it, debate it, work together, look at ways we can analyze it, present it to the panels to develop the recommendations. And just, having that novelty of a new treatment that comes through, like, looking at a trial that compares, favipiravir or some kind of antiviral, and then one comes through looking at kind of cow placenta as a treatment, which we didn't include, but, just looking at all these different data sets and all these different potential treatments, I think it stayed fresh for us. So yeah, although sometimes we can have a large amount of reviews or a large amount of studies that are published within a week, we might have, 10 to 15 studies that we have to review quite quickly. Other weeks, there might be a little bit of downtime. So we have a little bit of break from reviewing the evidence and can look at other aspects of the task force. But yeah, I think we've managed to stay quite fresh throughout the process. So.
Just to add to that as well, Heath, I think it's also been quite an iterative process throughout. So, you know, as time's gone on, we've kind of established more and more of our processes and how we go about doing things. And, you know, we've established those relationships with the panels, so they sort of know when to expect, you know, and our evidence synthesis and how to kind of, you know, manage that process a bit more. So that's really helped with the kind of reviewer fatigue. Because we've kind of gotten more used to exactly how our processes are, as opposed to in the beginning, we were kind of, you know, just trying to figure out what the best way to do this thing. And I think now we've got a really well-oiled machine almost of how to go about it. So.
Can I add to that as well, David? Just in terms of review fatigue, I think it also could extend potentially to our panel members and to our the members who sit on our guidelines leadership group and steering group. And I think we made a decision very early, and a very good leadership decision, Gillian's not here to take the credit, about really clarifying the decision-making capacity at each level. And so I think it was really clear from the outset who was kind of in charge of making what decisions. And so that really helped the teams to know what sort of information to present, so that you weren't overloading your panels or your guideline leadership groups, group members with information that could have been considered, you know, maybe by the evidence group or others.
Thanks, Sam. We have another question from Ren Statting. And he said, or he or she, I am from the Philippines, and we actually did our own living clinical practice guideline for COVID also, referring frequently to our international counterparts. However, we did experience challenges in looking for evidence reviewers with adequate technical expertise. How could LMICs work around this limitation and still come up with living evidence synthesis and recommendations? Anybody wants to take this question?
I'm happy to jump in, David, if you like. I think it's a great question. It's something that's very close to the hearts of a number of people who are in the team. So first of all, Kustika, welcome to Engaging Evidence, Stanley. I think this is something that we've talked about a lot, and not just in the living guidelines space, but in existing guideline space. We've seen for a long time that there's been an opportunity which hasn't been taken up really to collaborate as a community and share some of that evidence work. So I think one thing that we've been really excited about with the Living COVID guidelines is that we have been able to establish some of those collaborations, for example, with NICE in the UK and more recently with the Danish Health Authority, looking at being able to share the evidence reviews that underpin the recommendations within our guideline. Because in many cases, the evidence review is a similar output, but the recommendation in each context is going to be different. So I think there is a real opportunity, and tools like Magic and other similar platforms give us the opportunity to be able to share that evidence work between and across countries. And I think it's also something that we just, it would be great to talk more about. So I've sneakily copied your email address from the attendees list, and it'd be great to have some more conversations about that too. I think it's something, there is more and more opportunity for us to avoid duplication and share that living evidence synthesis work across contexts.
Yeah,
Josh, I can see
you. Yeah, thanks, Tara. Yeah, just to jump in. I mean, one is that while the living evidence and living guidelines space around COVID has been, a real success story in terms of international collaboration and, sort of a growing understanding about which groups or institutes are taking responsibility for certain types of activities, you still see a huge amount of duplication and in that sense, redundancy and inefficiency that could still be avoided. I mean, I think in some sense, the kind of critical mass of expertise of people who are really in the living methods world is probably still growing and will only get bigger. I think the same happened with GRADE, some years ago. It started from a small pool of experts that became much larger. But at the same time, I think, the critical part for LMIC context is also to think about the translation of those other living guidelines into local contexts. So it's not just that living expert methods, it's also that critical adaptation piece, which I think is something that we've as a guideline community, all been sort of thinking about and working on for many years. So that's something that I think still needs a lot of work, certainly in the living guideline space. But how do you ensure that a living guideline developed in another setting or another context works well in your context?
I think too, maybe just to follow up on that, David, we should note that we were in a very fortunate position back in March 2020, which feels like about 2 decades ago, that we actually had a team of people who'd done living evidence work in other guideline areas that we could quickly, I think the word that was used very often was pivot and draw into work on COVID. So the fact that we had that existing group of people with the skills in doing living evidence synthesis meant that we could quite rapidly spin up and respond and produce COVID guidelines. But if that hadn't been there, then it would have been a much more difficult undertaking.
Thank you. If there are no other questions coming right now, I will start asking some questions myself to our panel speakers. And my first question would be for you, Tari. I know you were speaking now, but I think it would be good to know how this idea came together, like the idea of creating the task force, of bringing all these people together, how this emerged.
Thanks, David. In preparation for this session, I went back and looked at my calendar for early 2020, and on the 29th of February, I was flying back from Geneva. I remember very well that I was sitting next to a man who was sneezing everywhere, and that this was annoying to me, but wasn't causing me to panic. Perhaps it should have, because of course that was the time before we had discovered that COVID was going to become pandemic, but not far before. So back in that very early period in March, Julian Elliott, who's spoken a couple of times at this conference, Rhiannon Tate, Sally Green and others quickly realised that we did have that existing base of people who had living evidence skills that could quickly come together and form a team to develop living guidelines for Australian care of COVID. So on March 11, you'll probably remember because it's in the introduction section of every COVID paper ever, a pandemic was declared. On March 15, Julian had a conversation with Anne Kelso at the head of the NHMRC about whether guidelines could be a useful contribution. On March 19, there was an email that went to the Health Minister, and on March 23rd, the task force came into being. So, I mean, that was kind of how it all came. On March 23rd, we had 5 member organisations with the task force, and very quickly, obviously, that sped up, and we were able to include a wider group of people. And then 2 weeks later, on the 4th of April, we had our first edition of the COVID guidelines. So I guess it was just an acknowledgement that that we had some evidence skills that we could bring to the table, that there was a great need, and that there was a real willingness from everyone to pitch in and move really quickly at that time.
Thanks, Tari. I think that's showed us how quick we move, how fast this was established, and the importance of having this voice, this unique voice. My next question is going to be for Heath, and I want to ask you about how do you recall these first meetings, these first appraisals of the first studies that came up. How do you recall that moment? Was there a changing point?
Yeah, thanks, David. I think, it was a little bit chaotic at the start. Obviously, we wanted to get some runs on the board quite quickly. So we looked at kind of all the existing evidence out there to develop effectively consensus recommendations as we established the groups that were going to form our recommendations. For the panel that I've been most involved with, the disease modifying treatment and chemoprophylaxis panel, they were quite enthusiastic at the beginning, very enthusiastic, but quite trepidatious as well. Obviously, it was a new pandemic. We weren't sure what worked, what didn't work. We knew that there was a massive push to conduct and, design, conduct, publish study data quite quickly. So we knew that evidence was coming, but we didn't know when it was going to come in, what it was going to be, what the treatments would be. So yeah, some trepidation there, but I think we were lucky that there wasn't a big explosion of evidence at the beginning. So it gave us the chance to kind of, bring the panel together, let them meet each other, discuss, grade, and teach them about grade and guideline development for those who hadn't participated in guideline development before. So it was a good kind of slow start. And then when the first studies were published, I think there were a few studies on hydroxychloroquine and lopinavir, ritonavir at the start. And they were quite small. So they became only research recommendations, but just looking at that, it gave us a good chance for the panel to get their head around, MagicApp, so the platform we were using, how to kind of rank outcomes, kind of defining clinical thresholds for, clinical significance, etc. And so, yeah, by the time, we came around to actually looking at the big ones, or so to speak, the ones that we can kind of develop recommendations supporting its use or not supporting its use, the panel are quite familiar with MagicApp, with the process, with certainty of evidence, ranking outcomes, etc. And so, yeah, I think those first steps were critical in kind of building the confidence of the panel to kind of, make those judgments and make those positive recommendations in the future. So yeah, it was a bit of a slow start, but lots of enthusiasm, and they really got on board. And now they're just, they know what they're doing in and out. So we've had about 50 DMTC meetings since inception. So they're old hands now.
Thanks, Heath. I'm going to ask now Sam about you are the methods lead of the PCC panel, but you also work in other parts of the guideline. Can you tell us a bit about the question prioritization, how the process was done, how this first question came into the guideline?
Yeah, great. Thanks, David. So I guess in keeping with our living plan, we knew that this was going to be an ongoing issue, and we knew that from the very outset that there were going to be questions and topics that came up over time, and that these were going to evolve over time. So we did two things. We had a really clear scope, which was, I've got this somewhere so I don't get it wrong, but it's really about the care to provide. Okay, so our scope is to provide specific patient-focused recommendations for the clinical care of people with suspected or confirmed COVID-19, where care for this patient group differs from usual care provided to patients with similar conditions. And we will revise the scope as necessary in discussion with members of the task force, etc. So we had a really clear scope to begin with. We also set up a system for getting to learn about topics and clinical questions, consider these questions, and then feed them back to our potential end users and stakeholders and others. And so our system really involved getting the topics and the questions. And so people can, we identify topics and questions in a number of ways. As you presented before, we have a point on our website where people can send in their questions or topics or concerns. We also identify these through MagicApp. So MagicApp allows readers to post their questions and concerns right there. We also identify new topics and issues that are through our evidence searches, our daily evidence searches, and we use that also to monitor emerging issues and any other way that people really want to get in touch with us. We're really happy to identify new topics and questions. What we do when we get new topics or questions is that we take it to our guidelines leadership group, and we consider whether it's actually within scope. And if it's within scope, we also then we need to think about, do we prioritize this for now or later, or maybe way later? So we really kind of consider four things. We look at the likely impact on patient outcomes, the proportion of the population that's actually impacted by the particular issue, the extent of variation in practice or any clinical uncertainty in current practice, and then the likelihood of new evidence emerging. And then if our guidelines leadership group agrees that it's within scope and it is prioritized for action, then at that point, it then goes to one of our panels. And usually the panel works with the evidence team to kind of clarify the PICO question. If there's a topic that's considered within scope, but perhaps not a priority, or we're not quite sure yet, we will list that as so on our website, so that others who are wondering can actually check to see what we're considering, what we've considered previously, and what are our current thoughts about that. And it also means that if we do at some later point need to upvote something or bring it up, reprioritize it, then that's possible as well. So that whole system enables us to kind of keep maintaining, keep new questions coming in, and thinking about whether they're relevant as we keep going.
Excellent. I want to remind our speakers that if you have any questions, feel free to raise your hand at any point or write it through the chat, and we are happy to jump from questions to questions. So please go ahead and ask us. My next question is going to be for Saskia, and I'm going to ask you about, you have been chairing different panels, 3 panels. How has there been any challenge coordinating between panels? How was the process?
Yeah, thanks, David. So yeah, I was chairing the critical care panel, the hospital and acute care panel, and the palliative care and care of older people panel. So particularly, I'd say with the critical care panel and the hospital and acute care panel, there was quite a lot of overlap for some of the recommendations. And it was really important to have those panels with, all the expertise in those particular areas. But then for something like, say, ventilation, that was really when it sort of started to cross over between sort of the hospital care and going into the ICU type space. So just having that kind of really good coordination with the chairs, particularly across those different panels. So we would have the clinical chairs from each of those panels also sat on the Guideline leadership group. So that was one way that, kind of brought together at the Guidelines leadership group some of those issues that sat across different panels. But there was also the kind of chance to sometimes bring in, when there was issues that really came to different panels, to bring in, say, a member, a specialist, an expert advisory group member, or perhaps one of the chairs from the other panels across into that particular panel that was looking at a specific recommendation, so that we really had all the input in the room that was necessary. And it was also, those evidence team catch-ups that we had last year, that was sort of, every morning and every afternoon we caught up with the evidence team and the other methods chairs, so we could really see what was going on in the other panels and what was relevant to our panel, and just having that really strong communication across the team was really helpful there. So yeah, I think that's it.
Thank you, Saskia. We got one question from Alex, and Alex Wool is asking, the guidelines have obviously accelerated living guidelines. How do we ensure these gains and profile are not lost over time?
I'm happy to jump in there, David, if you like.
All right.
Yeah, you're absolutely right, Alex. I think 2 years ago when we started this, living guidelines were an idea, and maybe there were 1 or 2. But if you do a Google search now, I think everybody and possibly their dog is developing living guidelines. So I think my concern is not so much that we will lose the profile or lose the uptake of living guidelines, but that we ensure that what are being described as living guidelines or living systematic reviews are truly living and continually updated, and that the methods that are used in living guidelines and living systematic reviews meet existing standards for rigor and reliability, so that we can ensure that that both living systematic reviews and living guidelines do what they're meant to do, provide clinicians with up-to-date, reliable evidence to inform their decision making. I suspect we won't go backwards in terms of the numbers of living systematic reviews and living guidelines that are being produced, but I think there is a big body of work to be done to make sure that the quality of those systematic reviews and guidelines is maintained, and that clinicians truly can rely on them.
Thanks, Terry. That reminds me also something Julian said on yesterday's plenary, that living guidelines are not living opinions. So we really need to ensure the great methods and robust evidence appraisal is maintained. I have a question now for Josh about what has been his experience with the pregnancy panel. If there has been any challenges, and how was the process of creating this specific population panel?
Yeah, thanks, David. So the task force has a couple of kind of special populations panels. I don't think there's a right or wrong answer to what and how many such panels you should have. That decision sort of came internally based on need. You know, I work in maternal health research, and in our field, there was a genuine anxiety at the start that, you know, pregnant women were going to be at greater risk or have worse outcomes from COVID, which has been the case with other respiratory viral epidemics in the past. What we've since learned is that pregnant women have a higher risk of worse outcomes than non-pregnant women. Of course, early in the pandemic, we didn't know if there was going to be a risk of vertical transmission, that certain practices that we have as part of our standard care were going to be risky or not. So there was a lot of sort of defensiveness in clinical practice in early 2020. So that was the sort of context of when we started the panel. What I think has happened, and is a complaint we always have in pregnancy research, is that pregnant women are being excluded from clinical trials. We know they have worse outcomes if they get COVID, but whether it's vaccine trials or drug trials or what have you, we're often lacking direct evidence. That means that we're either extrapolating evidence from non-pregnant adults to pregnant women, or we're having to rely on observational data from when those treatments in some countries get used in pregnant women and someone then has subsequently done the observational research. So research comes later and it's lower quality. So the way to solve it is to obviously get pregnant women into the trials, but we're in a decision-making framework in the pregnancy panel that often differs from other panels where they're working with more direct and reliable trial evidence. And we're also having to consider additional safety considerations. You know, what's the risk to baby in terms of their development, in terms of transmission and what have you. I think our recommendations ended up sort of in two piles. One was when you take recommendations about COVID-related treatments, do they or do they not apply to pregnant women? Which ones are we comfortable using or are we not? And you end up making a lot of conditional recommendations. And the second was, you know, recommendations to reinforce why standard care practice is important. And, you know, to be honest, that's probably one of the major harms for pregnant women during the pandemic, has been just not getting access to routine care. So, you know, about half of our recommendations are not groundbreaking in an evidence sense. They're saying we do, you know, labour companionship, or we do mode of birth based on these medical indications, or skin-to-skin contact, because we know they're effective. They have these benefits, and we've known that maybe for decades. And a risk or a concern about COVID is obviously needs to be appreciated, but we're weighing that against substantive known health benefits. So there's kind of a make sure to not throw the baby out with the bathwater type situation. That's a terrible analogy in this context. So yeah, I think, you know, living guideline panels still have a role to play in this context in terms of reinforcing standard care. And monitoring new evidence around standard care practices, as well as emerging treatments and how they might apply to populations. And that's where you really do need that expert lens to help you interpret weak or indirect evidence that is unlikely, frankly, to resolve in the near term.
Thanks, Josh. I think to highlight the one important thing here is that at the beginning, when there is no evidence, or this function of the guideline of reassurance for clinicians, of knowing that the things that they were doing are right, or there are no new evidence that contradicts that. Is that right? Yeah.
Look, I understand where the sort of defensiveness practice logic comes from. We don't know if it causes harm, so we have to sort of take appropriate steps to sort of minimize risk. But very quickly we were seeing organizations around the world putting out recommendations saying that mothers and babies should be routinely separated at birth. You know, that mothers should be routinely given a cesarean section if there was COVID or a suspicion of COVID. You know, these are not measures without harms. And, you know, obviously it's a difficult situation. We were operating in an imperfect world in terms of knowing transmission risk and harms to baby. But that's where those guideline organisations that are looking at up to the minute evidence and saying, listen, we do not have an evidence-based rationale for that practice now. If there is tomorrow or next week, we may change our position. But right now that the benefits of established care practices are important to reinforce. That was, I think, a really important measure to reinforce in a fast-changing situation.
There is a question from Priya, and I think it's for Saskia. Oh, it's from Saskia's presentation today. So the question is, I was on Saskia's presentation yesterday where she talked about steps in the review cycle of living guidelines and mentioned that at some point the guidelines would exit the living methodology. Are the COVID guidelines anywhere close to it? What would be the criteria to exit the living review cycle? Do you want to take this, Saskia?
Yeah, thanks, David, and thanks, Priya, for your question. Yeah, so we have sort of done a bit of a reprioritization process recently in the COVID guidelines. We haven't officially sort of had any completely exit living mode, but we've had some that we've kind of deemed as a lower priority recommendation. So we put them as low, moderate, and high priority. So some of these criteria really goes back to kind of that, what should be appropriate for living. So the uncertainty, and so we've had some where, there is maybe no new evidence occurring, but we still think that the question is uncertain. So we want to keep that living because we want to make sure that if something comes up, then, we still need to answer that question. There may be also areas where there is high levels of certainty, but there's still some controversy. So whether that's clinical controversy or whether that's from sort of the public, and that's a high priority sort of recommendation to keep track of for stakeholder interests as well. So the three criteria again, is uncertainty, it's whether there's new emerging evidence, and whether it's high priority. So that's also where the prioritization then comes in. So we've had some, particularly the disease modifying treatments, which over time have been sort of seen to be the strong sort of treatment options that have been emerging. And then we have had others where we've had some small trials come out, but then they sort of petered away a little bit. And we've sort of said, well, they're lower priority areas than some of the stronger recommendation or high priority recommendations that we've kept track of. I don't know if Tari or Heath, if you wanted to jump in on any of that.
I think that's exactly right, Saskia, as you've described. I think we now have about, Heath will be able to correct me, but like more than 50 recommendations, which are for small treatments which were initially tried but haven't been picked up any further. And for most of those, like Heath, calculus from supplement, but also a whole range of other interventions. We don't think it's likely that there's going to be any evidence emerging for most of those treatments. So those are low priority for us. We haven't taken them entirely out of living mode, but we don't expect to update them. The guidelines themselves, so there's kind of two levels of living, isn't there? There's the living recommendations within the guideline and the living COVID guidelines as a whole. I think the living guidelines themselves are going to be living for some time yet to come. We're still learning a lot every day, and so there's no plan yet to take them out of the sort of living mode. But the criteria that Saskia and Samantha have outlined would be the ones that we applied to determine when we thought the evidence base was stable or there was no longer any clinical uncertainty.
And just to add to that as well, Tari, that you can also go back through some of your guideline recommendations. So we did sort of look at how often had we actually updated that particular recommendation, how often was new evidence emerging. So as time goes on, it does become a bit easier to reprioritize because you can sort of look back and use that to inform your ongoing process.
All right. I'm going to ask a general question to the public. Is anyone involved in living guidelines or are thinking on developing living guidelines? Because I would also want to hear your experiences or your ideas or your questions in terms of developing a living guideline or what you would need to develop a living guideline. So if anybody wants to jump in or raise their hands if they are considering living guidelines, we're happy to take them. I'm going to move now into more organizational aspects of the guideline, and I will ask Tari about how did you manage to get all these organizations sitting in the table. We have seen in the slides a bit of the process, like from recommendation development to guideline leadership group to steering committee, how you make this process work so well and so quick.
Thanks, David. And of course, here the credit goes to others. So Julian Elliott, Rhiannon Tate, Bron Morris Donovan, and others were really the people responsible at the very beginning for pulling together the organisations that formed the task force. I think it took a lot of phone calls and a lot of emails in those very early stages to draw together 32 organisations who all had an interest in providing guidance to their clinicians around COVID care. I think it's really the first of its kind. We were keen from the beginning to be able to provide one source of guidance for all Australian clinicians so that there would be clearly aligned and no conflicts between different sources of guidance. And it was the basis of lots of phone calls, lots of conversations, but it actually came together very quickly. People were super enthusiastic about getting involved and about being engaged in the process. Lots of organisations wanted to be developing guidelines, but didn't have the resources internally or couldn't do it quickly enough, and were happy to work with us as a collaboration. I think it's also worth noting that the process has been perhaps surprisingly smooth. The 32 organisations that are the member organisations of the task force don't always agree on everything or work together in harmony, but in the almost 2 years now of the task force running frequent meetings and lots of potentially controversial decisions, the members of those organisations have really worked together incredibly well with great collaboration, lots of rich and productive conversations, and a willingness to engage, which has just been remarkable. There's been times in this pandemic where my 10-year-old son's been overwhelmed by the scale of the horribleness, and I've been able to say, look, we have these 32 organisations, these hundreds of people who are giving their time freely, look for the helpers. And it really has been incredibly heartwarming to see how productively people have worked together. There's something about the pandemic context. I'm sure we all wanted to pitch in and do our bit, and that's true of member organisations as well as the individual clinicians. But I think beyond that our experience has proven that it's possible. It's possible for this whole sector to work together to provide unified, reliable guidance to Australian health practitioners. And I think I would not necessarily have predicted it would go as smoothly as it has, but I'm delighted that it has.
Right. Thank you, Terry. I have now a question for Heath, and it's about as methods list of the disease modifying treatment panel, and you have been reviewing many of these drugs that has been coming, and sometimes we laughed when we saw what was this new very small RCT. But there has been a few of those drugs that has been especially controversial, such as hydroxychloroquine, or more recently, ivermectin. Can you tell us a bit of the process on how do we manage this in the guideline?
Yeah, certainly. No, that's a good question. I mean, obviously, I think everybody's aware of controversy around people supporting the use of ivermectin, even though the evidence doesn't support its use. There's been some quite outspoken people there, and they've kind of let us know their feelings on numerous occasions, which has been quite interesting, to say the least. But I mean, the key to approaching things like hydroxychloroquine and ivermectin is just consistency. I think, just use the consistent methods. Obviously, assess studies the same way you would any other study, do the risk of bias. If there are any issues with the studies, the design or conduct or reporting, then obviously you downgrade, and that's reflected in the outcomes and the recommendations that comes out. So I think, the key is to just not obviously differ from what you're doing, be consistent, apply the same rules to all treatments, and make the public aware that you're not treating anything differently. You're looking at the evidence as it comes in, you're being consistent. And generally they accept that. I think the main issue they would have had with things like ivermectin is not the way that we've interpreted the evidence that we have used. It's the fact that we haven't used certain evidence that they want us to. So there's a lot of kind of ecological studies out there. There's a lot of anecdotal data that, and some small poorly conducted observational trials, etc., that people are saying, look, there's, you know, all these trials with thousands and thousands of patients saying ivermectin works. Why aren't you using this evidence? And well, it's, you know, first, it's not trustworthy. It's not, you know, verifiable. Usually it's kind of poor quality. And so just maintaining that we're looking at randomized control trials, because that is obviously by far the highest quality evidence. And it's not that we're not including trials. I think for ivermectin, we're at 16 trials at the moment, randomized control trials that we've included. So it's not that we don't have the evidence there, so the evidence isn't showing us what the passionate people would like us to suggest, i.e. they want us to promote the use of ivermectin. But yeah, it's just kind of being consistent, I think, and just, you know, using high quality data, ignoring all the chatter in the background, and just being methodologically robust and transparent in what we do. So.
Thanks, Heath. I'm going to ask Samantha a bit about consumer involvement and also like how the primary care panel has evolved now with taking questions also on post-acute COVID and how the process has been.
Thanks, David. I might take the primary care panel one first and then consumer involvement second, so because I'm sure the others all want to jump in as well. So the primary chronic care panel was one of the earlier panels to get set up, and it has changed over time. So to begin with, the focus was primarily on mild COVID symptoms, and we, like others, you know, had issues of very little evidence, very little high quality evidence to base recommendations upon. So we followed the same process. You know, we kind of set parameters around what types of evidence we would require to make a recommendation. So for some instances, we said we'd only take RCTs. Others, we said we would look at high quality systematic reviews or other high quality guidelines, such as NICE guidelines. And so that was really important, I think, to set that parameter. And also sometimes we said, you know, we might take information or evidence from other diseases like SARS or MERS, but not always. So we did that for ACEs and ARBs, but I don't think we did that for anything else. And that's settled down. That's one of the deprioritized questions now. So the primary chronic care panel has been really interesting to work with because it's quite a varied. It has quite a varied membership. So you've got members who are GPs, nurses, OTs, respiratory physicians, even more. And we've also got experts to call on now. And this has actually been an evolving phase as we understood about COVID and then now post-COVID. So when, for instance, if I can just spend a minute talking about post-COVID, when around September last year or a bit earlier, we kind of became aware of the issue of post-COVID. It was one of the topics that was being raised, but we didn't, at that time, didn't have sufficient evidence to actually know if it was a thing, if it was actually different from other post-viral symptoms, and if it therefore required different care in keeping with our scope. So we monitored it for a while and then decided that possibly it was something that needed to be addressed. And so the primary care panel actually, the composition changed, and we invited people with additional expertise to be able to address various aspects of potential post-COVID symptoms. And just to add to that, I think the additional thing that we've done is really collaborate with others, both in Australia and internationally. And so the primary, because a lot of our recommendations, particularly on post-COVID, have been consensus-based so far, or practice points and general principles about care, we really wanted to make sure that these were not just opinions of the people sitting around the table. And so we engage very closely now with the NICE, the WHO, the Danish Health Authority, Canadian Public Health Agency, and also with researchers in Australia as well, just to make sure that we are staying on top of the issues, that we understand the nuances, and we're very careful about making recommendations that are not evidence-based and that are consensus-based. Yes, that's been a really interesting step. I'm happy to talk about collaboration another time. But let's, your second part of your question was also about the consumer engagement, and I will expand this. I'll throw it to the rest of the team to jump in on these. But we established a consumer panel last year, and it hasn't been easy. So I think we should also say that there are aspects of the whole process that have not been easy, even though there are many aspects that have been surprisingly easy, as Tari said. So one aspect that wasn't so easy was establishing our consumer panel. And maybe the others can talk about some of that, but what we've reached now, feedback from the consumers that are part of it, is that they find that we, what we've tried to do is really listen to their needs and engage them in a respectful way. I think by setting up a separate panel as opposed to inviting them to participate on individual panels, it kind of allowed them that space to have the conversations that they needed to have. And as with all of our panels, all the feedback from each panel is, rated exactly the same and taken back and addressed in our guidelines. So that's been quite useful. Me personally, I think if you ever have the experience to the opportunity to speak to a consumer panel and for them to interrogate your work, it is amazing. I would recommend it every time, hands down. It really instilled in me a sense of accountability that whatever I was doing had to be high quality, useful, relevant, all of those things. And so I just think it's amazing. But I'd like to maybe throw it to the rest of the team.
Thanks, Sam. Anybody wants to add something about how our consumer involvement has been, how we approach it?
Sure, I'm happy just to jump in and add a little bit more to what Sam said. And just to echo that, it was a little bit challenging in the initial phases of the task force because happily, there were few cases in Australia, and so we had few consumers who had experience of COVID themselves. So that's a great problem to have, but it does make it a little bit difficult to involve consumers and get their preferences and values in a guideline. From the beginning of this year, we've had a consumer panel that includes a much larger number of people who've had an experience of having COVID themselves or being a carer for COVID. And the depth of experience that consumer panel has brought to our work has been enormous. They're a magnificent group of people. And I echo Sam's comments about the richness of their input. And just to add, we do have 2 consumers on our guideline leadership group, so our most senior clinical group. But I think that Sam's right, that having these separate panel where the consumers can spend the time talking about the issues that matter to them in detail has been really valuable. And I just shout out to the consumers on that group who are just fabulous and make a really important contribution to us in understanding what it's like to be on the receiving end of some of the treatments that we're recommending. And I think the thing that has come up for Sam and I in conversation with the consumer panel is that our guideline is on management and care for people of COVID. And I think at times we've run the risk of focusing on management without covering care to the extent that we could. And it's been really useful to have the patients, the consumers and their carers remind us of the central importance of the care in the healthcare system.
Do you want to add something, Josh?
Yeah, just a couple of points. One is, the task force had resources for consumer engagement, which is great. Guidelines should, but not all guidelines do. And I think, it's one thing to expect health professionals in the course of their duties to, provide time to work on guideline panels as part of their paid work. But, consumers, that's usually not the situation. And so I think one advantage of the task force model has been engaging people in a sincere and adequately resourced way. I think engaging consumers in a dedicated panel, versus embedding consumers in a specialty panel, they both have their advantages and disadvantages. And I don't think it's that there's necessarily a clearly better option. I think one view is that having consumers engage at the time that the recommendations are formulated can have advantages, even acknowledging that they can feel disempowered and maybe a bit overrun in that context. And I think in the model that we're using with the consumer panel, it's also important to say to them, it's not that the recommendations are done or formulated, we need you to stamp it. It's that, we still want your genuine engagement with something, even though other groups or panels have looked at it before. The final thing I would say is that consumer involvement is really important, but maybe it's just one part of it. And this is where, potentially evidence synthesis for other parts of a decision framework, like, stakeholder views and preferences and patients' acceptability, we can draw on evidence now to help answer those questions. We certainly couldn't last year. The research wasn't there yet, but now there's a huge amount of work done about what patients consider to be important in a COVID context. So we can start to make those judgments in a more evidence-informed way as well.
Yeah, I'd agree with that, Josh. And I think it is one of the benefits of the living model, isn't it, that we can continue to revise recommendations as we get more feedback from consumers over time. It's not, this is a once-off, engagement opportunity. It is an ongoing relationship, and they can continue to revise and improve our recommendations over time, as can all of our panels.
Yeah, agreed.
Thank you. I'm going to ask first to Saskia, but this also is a question for the broad group and the audience as well. And it's our experiences surrounding collaboration with other international groups. I think some attendee has mentioned about the challenges of developing guidelines in lower middle income countries, or how we have been addressing collaboration. Can you give us an overview of what have been doing?
Yeah. So we have been having a few quite successful collaborations with some international groups. So Sam mentioned before the one that we have around long COVID. So we've been working with people in Canada, NICE in the UK, the WHO and the Danish Health Authority on some of those. So really kind of sharing search strategies, sharing evidence, even evidence profiles, or some of the sort of RevMan files, the analysis. Has all been sort of, been able to be shared across platforms such as Magic and things like that. And then we've also had some collaborations with NICE on some of the disease modifying treatments, which has been really great. And is it IDSA in America as well? So we've had the opportunity to establish some collaborations there, which has really been a back and forth, because we've had slightly different scopes and we've looked at slightly different questions. So just kind of knowing what other people are looking at and what areas, we could focus on and share with them, and what areas they might be doing outside of, things that we had previously been focusing on that they can share with us. But then further to that, I've recently, as a separate thing, had done some focus groups with some people from internationally across different countries about some of their experiences with collaboration. And they were really saying, particularly in some more the lower and middle income countries, and also organisations that perhaps didn't have quite as much funding. They weren't the sort of Department of Health organisations and things like that, but some of the smaller organisations, that there were some barriers there. They might not have access to Magic and things like that. So just thinking of other ways we could collaborate and kind of use, some things like just the basic, data extractions and things like that then people can apply to their local settings would be really beneficial, because that would then enable them to have, sort of a lot of that real bulk of the process done, and in terms of, the data extraction elements and things like that. But then really that contextualization and actually informing sort of their very different local settings would be really useful. But steps to do that, I think, is really important in future. But I'm not sure if anybody else wants to chime in on what else is going on in that space.
I'm really old, and when I was just finishing my PhD, I went to the Helsinki Gin conference. Don't Google it, it was a long time ago. And we were talking about, at that time, the importance of collaboration between guideline development groups internationally, and how many of us just felt like we could share the unit of whatever an evidence assessment was. That piece should be able to be shared between organisations. And I know that others on the panel and I have been talking about this for that entire period and really haven't ever seen it translate into real practice. Everybody agrees it's a good idea, but we've never kind of been able to make it happen. And so I'm just quietly thrilled and delighted, actually, like that we've been able to share our RevMan files with NICE, that they look at our reviews, that they come back and ask us questions, that they update us when they're updating their RevMan files. The Magic App gives us the option to duplicate our guideline and give it to somebody so that they can take away and adapt it directly. It feels like, coming back to Alex's question before, this is an area where we really do want to seize the momentum and make sure we don't lose the opportunities to share and collaborate in really practical ways. And I think we've made real progress. And again, it's been a really positive experience to be able to work with these people, again, who all have the same goals. We want to improve care for people with COVID, and we're happy to work together to make it happen.
Can I just add one thing around that? Is that we're finding that, so one, the collaborations that we've kind of emerged are not closed collaborations by any means. So, you know, we love the idea of sharing and talking to as many people as possible. So if anybody wants to jump on these collaboration groups, not really groups, they're just us talking to people, please contact us or one of the others, you know, and they'd be more than happy to hear from you. The other thing that I think has been really helpful because of these collaborations is that, especially for things like post-COVID, where there was so much uncertainty and there still is a lot of uncertainty, it's been incredibly helpful to talk to different people in different contexts and understand the emerging evidence well before it's published in any form, or the emerging kind of uncertainties and other issues. So I think that's just been incredibly helpful from our perspective as well.
I totally agree, Sam. I think there's also been an element of kind of shared debriefing about the challenges of the process that we're all sharing and facing, and that's been a valuable part of it as well. It might not be ever captured in a research paper around it.
And I think if I can just add, with our relationship with NICE as well, we've been collaborating with them since January this year, and it's been fantastic that it's been very organic. So obviously, normally when you have a collaboration, you'll have a contract or an MOU, or, you know, we'll give you this, we expect this from you in this time frame, etc. With NICE, it's just been really organic, and the process has worked fantastically well. And at the start, because they were developing their treatment guidelines, so obviously we had done all of these evidence analyses for hydroxychloroquine and all these other treatments. And so they were kind of like, you know, what can we give you to have access to those analyses? And we effectively said, look, we've done the work, just take them. You know, it's no skin off our back. So so they were looking to really reciprocate quite early, and then realized that, well, you know, we've done the work, we're happy to share, and they've kind of come forth and shared a lot of information with us on, as again, post-COVID and things like that. So, you know, we have plenty of meetings, we don't have agendas, we don't write minutes, we don't have kind of set discussion topics, but we just kind of, you know, chat about COVID, and everything just blooms from there. So it's been fantastic, just being very organic.
Thanks, Heath. I'm going to, well, we are moving to the last part of our session today. I'm just reminding the public, if they have any questions, now is the time to make them before we close. If there is anything else you want to ask. Of course, through the Engaging Evidence portal, there is also a chance to contact us, to reach out if you have any particular question or want to, as Sam was saying, explore collaboration. We are very happy to chat with you. And yeah. So yeah, if there are no more questions, I'm going to move to the last part of our talk today, and I will ask each one of our speakers to have some closing remarks, some take-home messages on how are our processes, where do you see guidelines going on forward, what do you think you have learned of this sometimes crazy experience of COVID-19 guidelines. So anybody wants to?
I can kick off. I think there's been a lot of learnings, and if I can summarize them, well, if I can just maybe think of a few bullet points. Having systems in place and the governance, I think, is like from the very get-go, has really helped us to move fast with clarity. So we could have moved fast and just ended up all over the place, but we stayed on track, I think, because of having those systems. We didn't really talk about this before, but so our guideline is not about, it's about developing a guideline, not about implementing a guideline. Yet that does not stop us from creating an implementable guideline. So I think we've considered that throughout the whole way by engaging with the various stakeholders, right from scope setting and key questions all the way to developing the recommendations. And then part of that, which we haven't really talked about, is our communications team and plan. And we've actually had that right from the get-go. And it's been absolutely, I think it's been incredibly helpful to keep everybody in the loop about what's going on and what's emerging and all of those things. And yeah, I think it's just my last kind of reflection is that it's been surprisingly fun. And so, yeah, that's all I have.
Thanks, Josh, you want to go next?
Yeah, I think sometimes when we talk about the task force, people say to me, well, of course, it was COVID. There was a huge amount of resources. The whole world was kind of working on the same problem. Of course, you can come up with these models. And something we talked about a lot internally is, it's not a special case. It's a set of tools and approaches that can and should be applied to closing evidence to practice gaps across healthcare. We had an opportunity to help deal with COVID, but also to use that as a springboard to kind of rapidly develop the methods and tools to do it for other types of problems. So, I mean, while the task force can seem like this kind of larger operation, I think internally we're also very focused on how do you do this sustainably and how do you apply it to other types of, perhaps narrower questions or even bigger health issues than just COVID.
Thanks.
Yeah, I totally agree with that, Josh. I think that's just been such a great learning experience because it has been that really iterative process where we've really, learned so much along the way. And now we can, look at what other guidelines have been doing. So whether that's outside of COVID in some of the other sort of ALEC, Australian Living Evidence Consortium guidelines, or internationally, and really pull upon that experience and now think, okay, what worked well and, what could be done differently next time and kind of, pull together some of those methods, which is something that we are currently doing and looking at kind of a how-to handbook of how to develop living guidelines, which we hope will be really useful for others.
David, if I might, my closing comment would just be to say thank you. Thank you to the people who've turned up today and been a part of this conversation. That's been really fun. A huge thank you to our magnificent task force collaboration member organisations who've just been the heart and soul of this work, and the literally hundreds of clinicians who've pitched into now more than 200 panel meetings that have made this possible. I just can't possibly thank them in enough places enough. And I think too, perhaps as this panel has demonstrated, or at least I think it has, thank you to this magnificent team. We do have, I think, a fabulous team of people who are, some of whom are represented here and some of whom aren't, but all of whom really just pitched in above and beyond the call of duty to make this happen. So thank you.
Thanks. We are a bit over time. Do you want to add something, Heath, or shall we close it? Yeah.
I just agree with all of my co-presenters. It's been a fantastic journey, and I do hope that the task force winds up soon, not because I'm bored with the work, but because the pandemic will disappear, hopefully, eventually. So
yeah, we hope that all of us. Thanks everyone for joining us today. And as I was saying, reach out to us. Happy to collaborate and to connect with you through the engaging evidence or from other resources. Thanks again, and see you soon. Bye.
Thank you. Bye.